And so again, the organism, is listed over here. Okay, so Aggregatibacter, Actinomycetum, comitans, they say very slowly, right? It's always associated, at least typically associated with aggressive disease. And then we looked at type 4, and we said this is associated, with systemic disease. And so on Monday, next week, we're going to talk about some of these diseases down here. But, and I have a couple of case studies that we're just going to look at. And so again, these are associated, with the systemic disease type 4. And then we have the necrotizing type, and I mentioned to you that we have the disease pneuma, which we'll see a little bit of today, and we'll say more about it on Monday. But we can see this necrotizing situation, where it involves really the whole face, in terms of the severity of the infection, and very devastating in children that have this. And so this is type 5, and then we had the abscess formation, and we can have this occur with types 1 to 5. And one of the things that we mentioned over here is that we can have a lot of inflammation, swelling. We can have exudate formation, and just at the bacterial level, purulent exudate. And then we had type 7, and so we have periodontitis associated with endodontic lesions. And so in this case, some of the same organisms that we've been mentioning can be found. But as we're going to see, we have another species of Papillomonas that seems to be more important in these type of lesions, and we'll talk about that. And then type 8, also associated, with congenital situations, or even acquired conditions. And these typically would require a surgical intervention in many cases. So we want to remember these 8. And so we looked at this to kind of contrast what happens, with caries. And so there we saw the progression of things, and we had the image that we looked at, which I'll just go back to real quick, just to remember what's going on in terms of the beginning of processes. But we want to remember what the white spot represents. Okay, if I can find the slide, we'll do that. Okay, and that's this image over here. Okay, and so the importance for going back to this is reminding what happens, so that that white spot, okay, that we see in number 2 is essentially what's initiating the caries process. So once we begin to have the demineralization affecting the tooth surfaces, and we begin to affect the enamel, the whitish color that develops, when light hits it, kind of projects this, whiteness back, and that's usually what initiates things. And then as we see over here, as we continue, to lose mineral, okay, we eventually get to this point where, the tooth is badly damaged. So again, those white spots are the initiators, okay, so that's the initiation of caries. So we want to remember those things. Okay, so what we want to do today is we want to look a little bit more at what happens during the disease process, and then we want to look at Papillomonas gingivalis to try to understand what kind of organism it is. Okay, I'm sure there's an easier way to do this. Sorry about that. Okay, so we had looked at this figure, and we wanted to understand, and again, if you have time, at some point, you may want to look at some of these articles, but other than that, we can talk about them the way we are. But we made the point, about the importance of Papillomonas gingivalis, right? So we talked about the red complex. Do we know what the organisms are that are found in that red complex? So we had Papillomonas gingivalis, denticola, T4 okay. So those, we have in here. And so Papillomonas gingivalis, again, is referred to as this keystone pathogen. because once we have the establishment of the biofilms and we have this, initiated, with the streptococcal organisms, once we get Porphyromonas in, we begin to see a lot of the pathogenic states that we've been talking about. And so part of, why I wanted to include this here was to say that, Porphyromonas, invades the cells of the mucosa, okay, which makes it even more dangerous. And, before it does that, it's able to use the fimbriae, okay, and the particular proteins, Fim-A being one of them, to attach to the surface of the bacteria, and using the beta-1 integrin as a receptor on the outside, okay, can gain access into the cell. And we also mentioned that it will generate this protease that will be able to this phosphatase will be able to activate cofilin, and we have this actin depolymerization that occurs, which makes it even easier for the entry into the host cell. And so once we do that, we set up these signaling cascades, a couple of which are pretty important here. One, going through the JAK-STAT pathway will end up, will end up preventing apoptosis from occurring. We, also generate these small fragmented, RNA molecules that eventually will enter the same pathway, leading to the blocking of the apoptosis. So what the organism does is it maintains its own survival as well as the survival of the host cell that it's in. And so the third thing we mentioned was that it also interacts with the pathways that would allow for toll-like receptors to be able to engage ligands and blocks that. And so in which case, we also affect the way in which innate immunity is going to occur. And so we wanted to look at some of the features of Porphyromonas gingivalis. So what we're looking at over here is, bacterial colonies on blood agar plates, showing the black pigment that lets us know that, we're looking at Porphyromonas gingivalis. And this, again, on blood agar, will show this pigmentation. But if we can grow Porphyromonas gingivalis on other types of bacteria, and we will not see this pigmentation in this way. And we can also have mutants that would have other colors, brown, kind of yellowish type looking things. But this particular pigmentation is associated with the bacteria. And so one of the things that we also need to kind of take note is that Porphyromonas gingivalis, unlike some of the other bacteria that have siderophores, which we looked at some of the features that bacteria have. These are the things that used to take up iron in media, right? Well, Porphyromonas doesn't have that, but rather uses its gingipanes, okay, for that process. So we want to remember this, this image over here. We're dealing with organisms that get in that red complex, the gram-negative organisms, the anaerobic, right? We have a triponema, with the spiral shaped, the Tannerella and Porphyromonas, gram-positive, gram-negative rods. And again, highly anaerobic. And so different from some of the other organisms we'll encounter. And so we have the features that make the virulent strains more pathogenic. And so we're looking at some of those features right here. So we have the gingipanes, which we've mentioned. So these are, proteinases. And just to make a kind of a fine point on things, the three members of the red complex, right, they're highly proteolytic, okay, which is, what makes them important in this disease causing aspect of things. And so we have the gingipanes. We want to remember that. So again, cystin proteinases, we have different types. So we have the arginine-specific proteinases, we have the lysine-specific proteinase, and the cells will use the gingipanes for a lot of different activities. So they will use them for the iron uptake, they will use them to evade host immune responses. They can degrade, using these proteases, they can degrade antimicrobial peptides. And in particular, ones that are produced by even the neutrophils that would be in the area, they can degrade those. A lot of the defensive molecules that are present, that are antimicrobial, those can be degraded. And they can also degrade complement protein. So like the CER5 complement receptor 5 protein can be affected by these enzymes. And in particular, they can interfere with the signaling process, as we saw in the image before, for toll-like receptor signaling. And so in addition to the gingipains, they have the fimbriae. And so the fimbriae, not uniform. We have, long fimbriae. We have, short intermediate type fimbriae. But we want to remember these adhesins, the Fim-A and the MFA1. We want to remember them. And so the Fim-A can be used to interact with, a variety of molecules on other bacteria in the community, within the biofilms. But we're kind of, pulling out one interaction here that's pretty important. So we have the MFA1 interacting with the SSB adhesin molecules from Streptococcus godoni. And so this interaction is important because, again, remember what's going on. We have the organisms, within this biofilm, and the interactions that are occurring there are important in maintaining the pathogenicity that would eventually occur. What's important to keep in mind is that the same interactions that are occurring between the adhesins from Porphyromonas gingivalis and organisms like Streptococcus godoni and others may have both a positive and negative regulation. And so this is important because, again, it helps to regulate, numbers of the cells that you have within the biofilm and so on. And then, of course, another molecule is the LPS, right? Again, these are gram-negative organisms, so we associate them with the LPS. And remember, when we compared endotoxins and exotoxins, right? With the endotoxins, with the LPS, when the cells, die, we can have this, LPS shed from that outer membrane, okay, which can become a problem if you have the cells undergoing division, right? We have large numbers of them, live, but undergoing division within these biofilms. A little bit of LPS, is also made available. But we mentioned that, the LPS molecule, right, a particular component of the LPS is the one that has all the, detrimental effects. And what component was that? The lipid A, okay, so the lipid A. Okay, so we want to look at what's going on, within the plaque, and what allows these organisms to establish themselves. And so again, as we have the dental plaque increasing, we have bacterial cells, also proliferating and increasing in number. And as they're metabolizing, right, we also have, production of, and actually maintenance of the extracellular matrix in there. And so as we have the biofilms being formed and we have the community of organisms present in there, we have ecological shifts from the aerobic, gram-positive, type organisms. So this would include the Streptococcus, lactobacillus type organisms, and that will shift, to these gram-negative, anaerobic, and facultative, type anaerobes that we now have in the plaque. And so this bacterial composition is important, and there are several studies. One, that I was looking at the other day, looking at what happens, in the reformation of the biofilm. So, for example, after there's been intervention and removal of plaque, and if individuals, now are not, maintaining their dental visits and oral hygiene and all of this, right? And you have the redeposition of plaque, and then you have the new biofilms being formed. And there's an interest in trying to understand, if there are shifts, changes in the organisms that kind of initiate the reestablishment to get back to the point where you now have the, red complex organisms, and then we begin to see disease again. So there's a lot of interest in those type of studies. And so when you have these changes in the bacterial composition, right, then you can begin to see disease states manifest if there's no intervention to remove the plaque. And so again, as we begin to mineralize, okay, the plaque, we form these hat deposits, and whether it's supragingival or subgingival, right, we're going to end up, having more calculus associated with this. And so we already looked at the results, of the bacterial distribution and the orange, yellow, and red complexes that we talked about. And so we just want to kind of take a step backward to see, how things were done. And so you had the study that involved 13,000 plaque samples from 185 adults. And so using DNA hybridization, the bacteria were identified, right? And so we saw the clusters, the red, the yellow, green, purple, etc. So out of this number and the evaluation of the bacterial types that were associated with the plaques, right, we had now this consortia of bacteria that were organized into the clusters. And so you had colonization in the biofilm on two surfaces. You had 4 clusters of those, blue and yellow. The early colonizers were the green and the purple ones. And then you had the colonization of a bacteria that was intimately associated with the pathology, right? The disease, and by those 2 clusters. So there was the orange cluster and then the red one. And then you had, a couple of outliers. So again, here's what we looked at, right? And so we saw this, large cluster over here in the orange. We saw the red complex right here, okay? And then, you had, the green, yellow over here. So a lot of the early colonizers, maintenance of and establishment of the biofilms, right? And then now you had the addition of these here in the red complex. And so, again, you have these 2 outliers over here, but we were focused on this complex right here, okay, to make sure we knew these organisms. And then within this group over here, right, we mentioned Escordoni. Okay, the one that can adhere and interact with Pocomonas gingivalis. All right, so some of the things that are done, again, the major emphasis is on reducing the bacterial diversity. So this goes back to what we saw before in the first week that we met, looking at the healthy mouth versus, where you had disease, the more diversity you had, disease state, the less diverse, healthy. And so again, the point is, trying to reduce the bacterial cell population. So the antibacterial strategies are for preventing and also for therapeutic control. And then maintaining effective oral hygiene, and so all of those things include, toothbrushing, flossing, and even using, antibacterial rinses can also fall in this category right here. And then, mechanical aspects of things, actually doing debridements, exposing the tooth surfaces, scaling, cleaning deeper to reduce the bacterial load. And so that's, a major thing for that. And as we said yesterday, people, every now and then you look in the literature, will mention vaccines and things like this, but, in terms of how effective that would be, that's the question, and so nobody has really put, the effort into it to really have vaccines that can be used routinely. And so a lot of things, that will happen will actually fall in this category right here. A lot of the antiseptic mouth rinses, antibacterial, that can actually help to keep the bacterial population down. And sometimes this is done in conjunction with, the mechanical aspects of things over here. So, that's something to kind of keep in mind. So good plaque control, right? And as the bacterial load lessens, and as the immune responses, able to now, manage the bacterial populations and so on, right? The pocket depth begin to improve, and so you have reduced, pocket depth. You begin to also resolve the inflammation that's taking place, and so again, all of these, can actually help to lessen the effects of the disease. And if we had situations, where the level of inflammation, level of infection was really high, and we now have, involvements in some cases, more systemic involvement, then antibiotic treatment, would also be something that could be used. But it is not routine, in terms of prescribing antibiotic treatments, for periodontitis. And so we have other pharmaceuticals that are used that, again, are aimed at reducing the level of inflammation. Okay, so remember what we looked at, the interaction, right? We looked at this and we said, again, we have the microbial challenge when the organisms are present, the antigens, being recognized, by cells of the immune system, right? Both innate and adaptive. And we have, the virulence factors that the cells, also produce and maybe expressed on their surfaces. And so we have the host immune response to that, and part of that response is, innate. We have the neutrophils. We also can have macrophages, monocytes, and as well we have antibodies that are produced. And there's some interest, in looking at the responses of things like, cytotoxic T cells, and what role they may have, especially, knowing that the porphyrin monas, is intracellular within these mucosal cells. And then, we have the products of the immune responses, going this way, trying to act on the bacterial challengers. But then we also have, products that will be involved in tissue destruction. So we have the matrix metalloproteinases over here. We have cytokines and inflammatory mediators. And when we begin to see connective tissue effects, bone loss, and so on, those are directly, from what the immune system is doing. And then we can see disease progression take place, and whether this subsides or, remains active has to do with how much microbial challenge we still have. So if we clear the antigen, right, if we clear the bacteria, reduce their numbers, then, we have less, antigen that the immune system has to deal with. If we still have a lot of bacteria, we're not cleared, right, then, this cycle, continues to go on. And so we have, genetic risk factors, which we saw, again, looking at the 8 types, of disease. And then we can also have acquired and environmental factors that can influence the disease as well. So, we have this over here, low diversity and richness of microbiota in gingival sulcus is associated with, so low diversity, okay, with the health. So again, keep that visual, in mind, right? So, with the less bacteria you have, the healthier the mouth is, the more bacteria in terms of diversity, the potential for disease now becomes pretty high. We talked about virulence factors, right? So major virulence factors on large segments of chromosomal or plasmid DNA. What was that? Anyone remember what we had looked at? Okay, the pathogenicity items, right? And we had the table, yeah, okay, all right. And then we looked at the antibiotics. We looked at the broad specificity tetracycline. Okay, so what does it target? So remember the different categories we looked at? We had effects of peptidoglycan. We had the plasma membrane, right? We had ribosomes, transcription, DNA synthesis. Okay, so which one? C. So the transfer RNA anticodon binding. Okay. So any aspect of protein translation that's affected, will affect the cells, right? Okay. All right. So if we have an antimicrobial agent that's bactericidal. Which one is this? Okay, so if it's bactericidal, then it's killing, Okay, remember bacteriostatic, okay, so reduce, the cell growth, but the cells are not killed. Okay. All right. So, a microbe isolated from periodontal lesions was shown to grow optimally at 36 to 37 degrees with high sensitivity to penicillin G and requirement for oxygen. Okay, everybody in agreement? So we're dealing with a mesophilic organism, it's aerobic, okay, and with the penicillin G, right, we have gram-positive because of the thick peptidoglycan layer. All right, so some additional features, to kind of think about, and we also kind of mentioned this yesterday, so we're not going to say too much about it. But one of the points that we just kind of want to keep in mind, and this will also help us as we look at some of these chronic disease conditions and congenital type conditions that make periodontal disease worse. And that point, is down here with the lack of the keratinization that we have in the gingiva. And so when we see some of these conditions where we have these floating teeth, so we mentioned these yesterday, where individuals are essentially losing the teeth, very, very rapidly, right? We'll see that we have effects, on that mucosa of the oral cavity, especially in the areas around the gingiva. So just to keep that in mind. Okay. So we looked at some of these factors as well. And again, in addition to the red complex, we had the Campylobacter rectus we mentioned over here. So again, red complex, plus these additional organisms, right? We can have, the aggressive situations that we have. And we've already mentioned, some of the things that can be done to control. But we have other risk factors, which is shown over here. So cigarette smoking, again, we can have, high rates of tooth loss, poor periodontal status. And again, a lot of this is not, it's not the smoking per se that's the problem, but, in most cases, the dental hygiene in the individuals is also problematic. And so together, those factors, can lead to a more worsened situation. And so if there's smoking cessation, that tends to improve the treatment outcomes for individuals. Chronic diseases, example over here, diabetes. Because of the large amount of glucose that's there, we can have protein glycation. It can enhance inflammatory processes and progression to disease. And so a lot has to be done here. On the one hand, we want to keep the numbers of bacteria down. But then, we also have the inflammatory processes that are underlying the chronic condition. And so this is one of those situations, where, both the dentist, and the medical professional essentially are working together, okay, to ensure that, glucose levels are down, A1C levels, regular, and so on. And so individuals may have to have cleanings and things like this done a lot more frequently, again, to keep those bacterial numbers down than individuals who don't have these chronic conditions. So instead of every 6 months, a person may be seen every 2 to 3 months, okay, just to make sure that, these bacterial levels are down and through the inflammation levels are down, and that there's improvement in the treatments that are taking place. And so, the point over here is important, having this less favorable response to therapy, and again, if the underlying inflammatory conditions, not well managed, it makes it really difficult to have that favorable response. And so this is another one of those places where, in addition, to whatever is being done physically and mechanically, the antibacterial rinses may become part of a program, almost daily, to ensure that these bacterial numbers are really kept low. And in some cases, depending on what else is going on with the teeth, fluoride treatments, may also be added, okay, to ensure that, whatever the therapy is that's now taking place is, favorable. So a combination of things have to be done. And so increased bone loss can occur, due to a coupling process between bone destruction and bone repair. And so again, this is something that's managed, for situations like this, where you have an underlying chronic problem. All right, so we have periodontal diseases with pathogenesis confined to gingival tissue with no loss of periodontal support. So which one do we do? Okay, right, C. Okay. And so in terms of the organisms, right, so we have necrotizing periodontal diseases, and they're associated commonly with the following organisms. Which one? Okay, all right, so A, all right, so remember, right, in the list? Okay. All right, so, okay, so something happened over here, just a minute. Okay. Now I get to run it. It's the wrong setting there. Okay, in your notes, okay, are you, what point are you at? I think
The next slide after what we had is periodontal bacterial species.
okay, yeah, I think I might have done something, okay. Let me get that. Okay, we here?
That wasn't what we had next, but I can jump to there.
Okay, yeah, so I'm trying to remember what I did when I sent you the notes. Okay, in any case, we'll just go on with,
there's a question a little before that. If you go back, what do you have before that? You have the control and prevention.
right here, okay.
Yeah, so we just skipped a few slides.
Okay, yeah, all right. So, so we've already actually talked about this, so we're not going to belabor it, like that. And so one of the things that we actually need to do is to look at some of these kind of rare, depending on where, you're practicing, rare type of diseases. And so what I'll do is, I'll just move with it, because I think I realized what happened. So we'll do the same thing we did yesterday, okay? We'll just kind of go over here and then we'll go back to the biofilms. But in any case, so we have a number of dental diseases that, we don't typically hear about, and you may not see patients, coming in with these type of conditions. But if you have, individuals, who, they may be malnourished, living in hopeless type situations, poor oral hygiene and so on, heavy smoking, that kind of a thing, they may actually develop pneuma. And, this is the pneuma disease, and another name for it is Camplomoris. So this can be seen, and some of the things that we talked about in terms of periodontal diseases, we see in very severe forms in these individuals. We also have, congenital type, situations. Papillon Lefebvre, we look at. We have a couple of case studies that we're going to look at. There's another one, that we have associated, with the severe disease and loss of teeth, the floating teeth I keep mentioning. We'll see associated there. And then we also have the protozoans, that are associated with periodontitis. And again, depending on where you live, where you're working, you may never see this, but a patient may come in, where this is what they have, in predominance, more important than the bacteria that they have in the mouth. And so the two important ones, Entamoeba gingivalis and Trichomonas tenax. So Entamoeba gingivalis is an amoeba. Trichomonas tenax is, it's a flagellate. And so these can be pretty important. And normally we think of these, as commensal organisms. We don't really worry about them in terms of, causing disease. But then if there are other things going on, with an individual, right, we may have these organisms actually be significant, in terms of a disease of causation. And so we want to just kind of look at what the pneuma looks like. And so again, we're seeing over here an example of what can occur. And so lesions may begin inside the mouth, and they can progress, to the surface of the skin. And so, in individuals like this, what typically would alert an individual that something is going on is the number of bacteria, the metabolic products that are being produced, and the bad smell that's associated, with large numbers of organisms. Lesions may appear, besides the oral mucosa, they may appear on the skin. And as we see, in this child, around the nose, mouth areas. And so when when the examination is done, there's a lot of necrotic events going on. So a lot of necrosis that's taking place. And so again, we see, when you take a look, inside the mouth itself, again, you can see the ulcerations that are occurring. And they're not limited, to the gingival areas. They can spread, to the cheeks, and we can actually have things break out, to the surface of the skin. And so again, this is an example of, pneuma disease. And so again, the necrotizing gingivitis, you can see over here a couple of examples. And so again, you can see, the swelling that's associated, with the gums. And, in this next section over here in B, you can also see the swelling, but you see the pseudomembranes, that form, and a lot of calculus that's there. And so again, in many cases, these can actually progress into more serious things, where the architecture of the face, is involved, and you can see a lot of losses. And so typically in cases like this, individuals, may not seek attention early enough, because then you have a lot of stigma that's associated, with what's now going on and the appearance of the individuals. And so, we can have, disfiguration that occurs. And again, people will tend to kind of stay away, and take a little bit of coaxing and encouragement to actually get them to be seen. And so in the literature, these types of conditions are associated with other diseases of poverty, and so on. And so we see this type over here. And so I just put these references in here, for those who are interested. You can get some more information. On Monday, when we look at the diseases and look at systemic issues, we're going to mention this again and look at some of the mechanisms that occur. So there's a lot about pneuma that's not very well understood. For example, because we have a polymicrobial situation, it's not really clear, what major organisms, are involved, because we have so many different species represented. Each one, or in combination, could be enhancing, the damage that's being seen. And so, one of the case reports we're going to look at, involved the papillon-Lefebvre syndrome, that we talked about. And again, one of the things, that happens, right, is a loss of teeth, the floating teeth, and a loss of teeth that would take place because the gingiva is so affected. And, we have it become erythematous red, it's swollen, and very easy, to bleed, upon probing. And so we'll see some of the thinking behind, why this happens when we look at the case studies on Monday. Amongst the protozoans, so we have Trichomonas tenax, okay, which we already saw. So it's commensal, prevalence, rates vary depending on where you are. And so it's found, in the mouth. And again, in this particular study, when they looked at individuals, about 28% or so of the frequency of having the oral pneumonitis in there. And so it is associated with other infections outside the mouth. And so, we have things like tonsillitis that can occur, submaxillary gland infections, pleural infections. And so it's important to remember that Trichomonas tenax is related to Trichomonas vaginalis. And so again, if we have the organism producing proteases that can affect, connective tissue and allow invasion, then we can see more of an effect, in terms of pathogenesis than just thinking about T. tenax as just a commensal organism. So it's good to keep it in mind. And remember that besides the bacteria, besides the fungi, things like Candida and so on, the viruses, that we also have these protozoan organisms that are important in the oral cavity. And so we see what the organisms look like here. And so these are trochozoid stages. And so we want to be able to recognize them so we can see them by wet mounts. So unlike the bacteria where we have to do the gram staining and so on to differentiate gram positive, gram negative, a wet mount can easily show these organisms there, but then they can also be stained by things like Giemsa, and some differentiation can be obtained to see what they are. These are flagellates, and again if they found in the mouth, it can be associated with periodontal disease. This particular study looked at different isolates, right, to try to understand, the level of protease activity associated with the isolates. And as again, you can see over here, the isolates vary. And so an important point to make from what we've been saying so far, right, so even with something like Porphyromonas gingivalis, we can have non-pathogenic strains of that organism. So if we don't have those virulence factors, we're not going to affect things the way we see with those strains that are virulent. And so even amongst the protozoans, we have strains that are more virulent, and we have ones that essentially just occupy that commensal role and can be in the mouth and not be associated with the disease. And so in order to find out the type of proteinase, in fact, the pattern of proteinase expression, where we have these gelatin SDS-PATE gels that can be used, and so this particular study used that to demonstrate, the pattern of protease activity associated with the different isolates. And as you can see, the patterns vary in terms of the digestion of the gelatin, and so again, depending on the particular isolate, the level of invasiveness that they're producing these enzymes will be much higher than ones that are not producing the enzymes. And so again, we just want to keep in mind that we have these organisms that are there. Excuse me. Okay, and so the next organism is Entamoeba gingivalis. And so this is, the first symbiotic amoeba that was described, in humans. And so we have other Entamoeba species. One which, you've been familiar with is Entamoeba histolytica. Anybody heard of that one before? Okay, and so we can have amoebic, dysentery as a result of that. We can have, extraintestinal locations, where the organism, can find itself, typically in the liver. But we can also have it in the brain and things like this. Go ahead.
What was the name of the other amoeba?
Histolytica.
Histolytica.
Yeah. And so, so gingivalis is related to that. And so, again, because of the capacity that we have for invasive, histolytica to take place, right? We can, kind of envision some of the same properties in virulent strains. And so, typically, when you look at amoeba, and if they have within them red blood cells, if they're taking up red blood cells, then that tells you that you're dealing with invasive strains, because they're able to take up the red blood cells. And so the cells can be found in the periodontal pockets. Again, prevalence rates vary depending on where you are. And so again, one of the questions in the literature is that compared to something like T. tenax, if the organisms are present they're associated, with disease. And so you remember the statistics we looked at yesterday, just how prevalent these diseases are, and we looked at them by age, right? So as individuals, increase in age, by the time they get to their 60s, right, they have quite a bit of disease, all the way up into the later decades of life. And so many times, again, depending on where you are geographically, part of that increase is not just bacterial, but also the presence of E. gingivalis as well. All right, so we want to look at diseases that we normally will not think about, but they're important, because of the things that we've been discussing. So remember yesterday we mentioned that Papillomavirus gingivalis is not just found in the mouth. So it can be found in other locations, in the body. But, once we have it in the mouth, we associate it, with the disease states, especially if we have virulent organisms based on the virulence markers that we've looked at. And so we have, Papillomavirus gingivalis, being described in the duodenum, okay, so a lot lower than you would expect, to see it. And so an organism that's been a very interesting one to look at in terms of distribution in the body is Helicobacter pylori, which is also gram-negative, and it colonizes the gastric mucus-secreting cells. It can produce things like urease, which can affect the pH in the environment, increasing it, and then can also produce toxins that damage the epithelium. And so this is the organism that's now been associated very strongly with ulcers, within the GI, the duodenal ulcers associated with this particular organism. And so in situations where there's no intervention, with the ulcerative states, of the epithelium, we can have progression, to cancer, so we can have neoplastic cells. And so this is described as a class 1 carcinogen. And so there's been a lot of interest in it because in some of the sampling that's been done that we talked about, right, where you have investigators, collect the plaque, from large numbers of individuals, and then they examine the plaque, they grow the cells out on plates, and then they examine to see, what organisms are being identified. Helicobacter pylori, has been isolated, from the oral cavity. So just like the Papillomavirus gingivalis, you'd expect to be in the oral cavity, being so far down, low into the duodenum. Here you have, different situation the opposite way, where the Helicobacter pylori is all the way up in the oral cavity. And so the question is, how is it, getting there? Why is it there? And is it just a contaminant? Okay, and if it's a contaminant, okay, then you would not expect to see this in a large numbers of people. But still, the very fact that it's there raises some questions, as to distribution within the body. So we have the organism being able to adhere to surfaces, so we have the same kind of fimbriae, so that's adhesives on them, so we can bind to the epithelial cells, right, on the sialic acid that we find on the surface of those cells. Excuse me. So we already mentioned the ureases, which can hydrolyze ammonia, making the environment more alkaline. And then we have, in addition to the ureases, we have other enzymes, proteases, phospholipases, cytokine activity that will increase inflammation in the epithelium. So other things that can occur, so normally when we think about H. pylori, we're thinking of, how it gets transmitted from, from individual to individual. Now, not every person who has, H. pylori in the GI is going to have ulcers or going to have, the cancers associated with the ulcers. But then again, remember what we've been saying, there's strain differences. And, excuse me, there are other factors that could be occurring within individuals that can predispose them to getting, the ulcers that we've mentioned. And so, transmission, from person to person, having a common source is something that people think about. But, you know, the evidence is not so strong yet to indicate that that's, you know, really all that's going on. And so how do we tell that the organism is there? Well, we can culture gastric biopsy specimens. We can look at stained biopsy specimens. We can do serological testing. The urea breath test is one that's, you know, pretty important, that's done. And so you can test to look for ammonia in urine, and then also looking for urous activity in biopsies and the things that are done. And so at the time when in the literature, ulcers were caused by every manner of thing except bacteria, right? You know, the preventive strategies and therapy, you know, was based on everything from, you know, cutting out spicy foods, you know, to, you know, reducing the level of stress and all these different things. But then, you know, once it was clear that this was something that was caused, you know, by Helicobacter pylori, antibiotic treatments, you know, could now be administered. And, you know, the reduction in the numbers of the cells, you know, once you killed, you know, large populations of these organisms, was enough, you know, to decrease the effects that you had as a result of the bacteria being there. So again, we're decreasing, you know, stomach acid, and then we're also killing the bacteria and being able to resolve, you know, the conditions that are developed as a result of the bacteria being present. So we also want to look at streptococcal diseases. And so before we get into those, you know, let's take a 5-minute break, and then we'll, you know, look at them. And so part of what we're doing is we're looking at these organisms, right, you know, to kind of understand the disease-causing process, to help us understand what the organisms in the oral cavity are doing, you know, when they also now contribute to the disease processes inside the mouth. And so we'll take a 5-minute break, and then we'll continue looking at the streptococcal diseases. Now, remember what we've been talking about so far, right? So we looked at gram-positive, gram-negative cells, right? And we had that dichotomous, you know, key thing that we looked at. So, you know, in that case, we wanted the major gram-positive coccal type organisms, you know, Staphylococcus, Streptococcus. And then, you know, the population of cells that we have in the oral cavity. So again, you're remembering that yellow complex, right, that we just looked at, right? We have a lot of streptococcal organisms there as well. And we mentioned yesterday that, you know, strep is not localized just only to the mouth. We have other streptococcal species that are pathogenic, you know, to us, and are localized in other areas of the body. And so we want to be able to kind of get an understanding about, you know, how pathogenic strep causes disease, and to see some of the things that these pathogenic species have that can actually help inform us on what's going on in the biofilms that we have inside the mouth. And so we're looking at the gram-positive cells, right? These thick peptidoglycan layers on them. When they divide, the plane of division, you know, keeps the cells, you know, in chains. And so we have this, you know, streptococcal arrangement. And so Streptococcus pyogenes is one of the most important pathogens that we have. So it is, you know, amongst the different groups, you know, of strep that we have, it's a group A, beta hemolytic streptococcal organism. And so we have, you know, again, the distinctions, you know, we have group A, group B, etc. But right now we just want to kind of focus on the fact that it's, you know, it's group A, it's beta hemolytic, and produces, you know, a number of virulence factors. And so we have enzymes that can break down, you know, host tissue. We have streptokinases, you know, that are used, you know, for clot dissolution. We have, you know, type O and S that can actually kill leukocytes. We have capsules, we have M protein, things that encourage, you know, attachment of the bacteria to host cells. And so we see that, you know, we have a wide distribution. Some individuals, you know, have S. pyogenes, but they're asymptomatic. They don't, you know, have disease. So they're essentially carriers, and we have a number of things like that. So we'll talk about Salmonella typhi later on with typhoid Mary and all of that, and we'll find out, this historic situation, where you had this woman who was a carrier for typhoid, and she herself would not get sick, but then because she worked, in the food industry, whenever she worked, people would get, the bacteria, and people would die from it and so on. And in the history of public health, she kind of stands out because of all the different things that we do in public health, quarantine, and all of the different things were done to her, but she would manage to be out there working, in the food establishments again. And so when somebody got sick, they would know that she was out working again, okay? And so we'll talk about, typhoid Mary as well later on. But in any case, she was a carrier. So it's a classic carrier situation where she herself would not be symptomatic, but then everybody else around her, who was susceptible, they would get sick, and in some cases actually, die from infections. And so transmission is through respiratory droplets. We can have direct transmission, or indirectly, droplets in the environment. The person shows up, they can now get, the organism in them. And so clinical and lab findings, are important for, identifying the fact that we have strep pyogenes present. And, so amongst the different diagnostic type tests that are available are these rapid diagnostic tests where you can get, answers, very quickly in terms of, what organism you have, and in this case for S. pyogenes. And so we have, an example of an infection, that's caused, and, so we all know what strep throat is and so on. So again, another name for it is streptococcal pharyngitis. And so again, we can have, droplets that are spread, nasal secretion, saliva and so on. And so we can have infection of the throat. So that would be the pharyngitis, or we can have the tonsils, tonsillitis. And again, signs and symptoms of the disease, right? They could look like other things because we can have viral infections that look just like this. And so being able to identify the organism is key, so we can rule out other things. And so typical appearance is the redness, that's there, the swelling, exudate, and so on, enlargement of the lymph nodes, and the throat. These are all kind of signs. And so the rapid kits are important to be able to make the diagnosis. Antibiotics are typically given, but then they can be sequelae that occur. Rheumatic fever can be there, and again, glomerulonephritis can occur. And so again, the idea is to have people, not exposed to areas where the bacteria may be available, and not have contamination that way. And so there are a number of post-streptococcal type diseases. And again, one of them is the glomerulonephritis we mentioned, also known as Bright's disease. And so it can occur, 1 to 4 weeks after an individual has had the infection. And so, it might be non-pus producing, but, in the scheme of things, the infections caused by strep are pretty important, pretty significant in different areas, not just within the U.S., but in the U.S., it's up there in terms of bacterial infections, that affect, large numbers of individuals. And so, we want to remember that this is a type 3 hypersensitivity, where we have, glomerulonephritis occurring. And so again, we have antibodies can interact, with the antigens that you have, from the organisms. You have immune complexes, they can deposit. And so when they do this, we can have inflammatory responses to those complexes. We can have complement fixation, for example, occur. We can have inflammation, due to that. And so again, we're going to see some of the same things that we see in other type 3 situations. Everything from hematuria, blood in the urine. We may have lesions heal, or they can become chronic, depending on what's going on with the individual. And so again, being able to confirm that the person had prior strep infection is important. And so again, the idea is that treatment needs to kill any remaining bacteria. Beyond that, not much else is done, so that things can get resolved. And the rheumatic fever is the other manifestation. So again, this is autoimmune, so we can have, involvement, with the heart valve. So we can have organisms, present, in locations where they should not be. And so again, when that happens, we can have, inflammatory responses that can take place, and, we can have involvement in other aspects of the body, everything from subcutaneous tissue to central nervous system involvement. And because you have different presentations of the infection, streptococcal etiology may not be the first thing that comes to mind, but because this, with the involvement of the glomeruli, seeing the streptococcus, having that history of knowing that an individual may have had a streptococcal infection is important to actually help in the way in which things are managed. And so again, inflammation is pretty important, and so being able to reduce the inflammatory activity is a good way to kind of control the infection and the effects. And so when we have the organisms around the heart valves and inflammation directed towards those valves, being able to reduce the inflammation, will also help to control the cardiac effects. And so when we look at systemic diseases arising from the oral cavity, right, we're going to say these same things again. Because, during dental procedures, if we have high bacterial counts, right, we can have some other bacteria, get into the lamina-appropriate areas, get into the capillaries, and, travel in the blood vessels, and, we can have them end up in the areas, around the heart valves. And so, again, you see, how important that is over there. And so, using salicylates, corticosteroid treatments, usually done. And so we want to see how these differ from staphylococcal type diseases. And so we have staphylococcus, we think of Staphylococcus aureus, we have different strains. We have Staphylococcus aureus, on the skin, different parts of the body. We have it, within the respiratory areas, the areas, oropharynx areas close to the mouth and nasal cavities. And we have different strains of Staphylococcus aureus. Ones that are just essentially benign, okay, really will not cause any problems just by being in the surface of the skin unless they penetrate the skin. And then other strains that really can be disease-causing. And so again, if you think about that dichotomous key that we looked at, right, we could break things down. If we started to see coagulase production, things like this, okay, we're dealing with more pathogenic type situations, or at the very least, organisms that can be opportunistic, okay? And so, compared to the streptococcus that we have in chains, right, the staphylococcus, we can have them, in pairs, in tetrads, or more commonly in these clusters that are referred to as grape-like clusters. So when you do a gram stain, Staphylococcus aureus, you can see this characteristic, grape-like clustering that's there, and you know that's what that is. So these are facultative anaerobes, catalase positive typically, and as we've already mentioned, we'll have them in the upper respiratory tract, on the skin, we can find occasionally in the intestinal areas, in the vaginal areas. So these organisms, again, normal commensals, but again, we have strain differences. And so, Staph aureus, again, coagulase positive, allowing us to know that this is a pathogenic strain if we can do this. Staphylococcus epidermidis, one of the other species, coagulase negative, less pathogenic, but, can be an opportunistic organism. So in nosocomial situations, hospital environments, institutions, that kind of a thing, you can have, infections, with epidermidis. And they produce slime, those that are pathogenic. And if you remember, on the gram-positive cell wall, right, the peptidoglycan, we have the teichoic acids, right, everybody remember that? The lipoteichoic acid is also present. And so those can provide pathogenicity for these organisms as well. And so the slime that's produced, is pretty important. So amongst the things that we've talked about for virulence, right? So we've mentioned fimbriae, everybody kind of remembers that. We mentioned capsule, right? And so now we have, this slime. So on the fimbriae, we have the adhesins, right? So here, we have this extracellular substance, that's produced, pretty thick, okay, viscous, glycoconjugate. So we have carbohydrate moieties associated with it. And so just like the other things that are adhesins that the bacteria can use to attach to substrates, they can also use the slime to attach, to surfaces and form these biofilms. And so, like the capsules, when we talked about them, we said that organisms that produce the capsules can actually evade phagocytosis. So, evade phagocytosis from neutrophils, evade phagocytosis, from monocytes, macrophages. And so again, here, the presence of the slime is important for inhibiting neutrophil chemotaxis, also inhibiting phagocytosis, and also, preventing the effect of antimicrobial agents from destroying the cells. So a lot of the bacteria that are pathogenic, as we've already talked about, they produce these virulence factors, and some of these virulence factors are actually aimed at evasion of the host immune responses, both innate and adaptive. And so something to keep in mind in terms of the similarities. And so we can have, individuals that have disease-causing or pathogenic, Staphylococcus species or strains, and individuals can be asymptomatic. So the carriers, they don't get sick from this stuff, but other people who are, are susceptible can succumb to infections caused by Staphylococcus. And so one of the things that's also important for virulence, we mentioned this before, is the exotoxins, and we talked about the superantigens, and Staphylococcus can produce these, and so we can have the organisms spread by just contaminated hands, fomites, inanimate objects. We can have them through the respiratory tract. People when people sneeze, cough, that kind of a thing. Droplets contain the cells, and so we can have disease from these organisms in pretty much every organ and tissue of the body. And so if individuals are immune competent, okay, the chance for opportunism is less compared to individuals who are immune compromised, okay, or not competent immunologically, and they will be most at risk. And so what this table is showing, and we want to look at is, and we've shown this before, is that we want to make sure that we kind of recognize the components produced by Staphylococcus, right? So we already mentioned catalase, we mentioned coagulase, right? We mentioned the beta-lactamase, the penicillase, and we talked about hemolysis. Everybody kind of recognize those from the table? Okay, so we had those things. And then we talked about protein A, right? And we mentioned that protein A was not produced by the bacteria, so we could use it to do pull downs or immunoassays, right? But it's actually a substance that's produced that's used for evasion of the immune system. We have protein A, we have protein G, protein L, all these different things that we use. So a lot of the protein A that's used, in labs these days is recombinant. Okay, unlike when we first started using formalin fixed from Staphylococcus with the protein A to do immunoprecipitations, it's no longer quite that way. But in any case, so they can produce protein A and a variety of other proteases. And then at the very bottom, right, the toxic shock syndrome, right, the superantigen that we have. And so this is one of the ones from Staphylococcus aureus that was initially studied, and I think in the literature there's a lot more known about it than some of the other superantigens because it's been studied for so long. And so again, this table, we want to use it, to recognize the various products that we've talked about. So again, the lactamase, catalase, coagulase that we talked about, the hemolysis, and then down here, the toxic shock syndrome, toxin, right, the protein A that we talked about. And then generally, If we have an organism producing lipases, we just need to remember the association that we're going to be able to clean lipids. If we're, producing things like, nucleases, we can break down nucleic acids, and so on. Okay, and so again, use this table to look at these different molecules and the importance that they have for virulence for Staphylococcus. All right, so we look at some of the examples. So we've mentioned a number of things that bacteria need for invasiveness. So when we looked at the image, of the interaction between the bacterial challenge, the response of the immune system, all the way to systemic conditions that develop, right? We saw in there the matrix metalloproteinases, that are important in helping to break, break tissue down. And so if an organism is producing exotoxins and proteinases that, can break down, extracellular matrix, basement membrane, and so on. These are, dealing with invasiveness. Okay, so if we're breaking down collagen, we have collagenases, for example, hyaluronidase. This is all associated with, the ability to invade the tissues and to get beyond the mucosal surfaces and to be able to get down deeper into the tissues, to where we're now in contact with blood vessels, and we can now be transported, with the vascular system. And so we also mentioned that the production of toxins and in some cases, antimicrobial agents might be on plasmids or phage. So we can have the genes encoding toxins, the genes encoding the particular proteins that are aiding the antimicrobial process actually be on the plasmids themselves. And so, which means if we're in the biofilm and we have this community of organisms, we can exchange, plasmids and essentially confer resistance to organisms that ordinarily may not be, but now they are because they have the plasmids within them. And so, in terms of the toxins, right, so we know endotoxins right now, the gram-negative, then we have all those exotoxins, right, that we associate with the gram-positive cells. And so, just to see an example of where, exotoxins might be important, many of the times that we have organisms that produce toxins that contaminate food, right, we can have, food intoxication, and that's as a result of these enterotoxins that are being produced by the bacteria. We can also have, abscess formation, bacteremia, as a result of, organisms that are producing, these toxins as well. And so we're looking at an example of abscess, formation, localized. So we have, Staphylococcus aureus infected hair follicle. So these are one of the kind of more common type of infections, that people will get. And so as a result of this, we can have, tissue necrosis. The coagulase, gets produced. We form this fibrin around that lesion, so it kind of contains the bacteria in that, focal place within the follicle. And then if we have liquefaction of the necrotic tissue, right, then the abscess spreads and we can move the organisms, to other areas. And so all of those things, boils, carbuncles, those type of things, we have originated from Staphylococcus aureus type infections. And so again, if we have the bacteria into the blood, we can move it to sites far away from the local point. We can spread it also through the lymphatic system, the lymphatic vessels, and we can get the organisms, farther away from, from where they first came in. Other examples of infections caused by Staphylococcus. So we have Staphylococcus scalded skin syndrome. And so again here, we have a strain of Staphylococcus aureus that has an exfoliative toxin that's encoded by plasmids. And so that toxin, is the exfoliatin. And so here we can have the epidermis, peel off, okay, as a result of the presence of this toxin. and then we, have this redness, that can be visible. And so again, the idea is to be able to identify, the Staphylococcus strain that's doing this. And as we've seen, again, from that dichotomous key, we have all those different tests. We can essentially, tease them out, okay, to find out, what particular cell, first of all, and then what strain is present. And so, again, the different things that we're already familiar with, right? So, being able to isolate, identify, right? Using the catalase, coagulase test so that we know we're dealing with Staphylococcus aureus. Serology, using antibodies, that can recognize antigens, from staph. Doing DNA fingerprinting, that will help to establish the strain differences. Phage typing can also be done. So again, I just want to kind of remind again, if we have bacteria, we don't want to forget plasmids and bacteriophage. Okay? So if you have the bacteria present, their plasmids will be around and their phage will also be there. And in the case of the phage, we can have some specificity associated with the phage being able to adhere to and enter into those host cells. And so antibiotic therapy is important, and again, as you know from different things that we're reading about and in the literature, we have these drug-resistant Staphylococcus strains, which is a real problem. And so so again, combinations of antibiotics and so on important. And in cases where we're having contamination, things like food, personal hygiene, being able to do things, aseptically, helps to manage lesions that are caught, that are formed. And then, we already mentioned the toxic shock syndrome. And so the key thing here is that we want to remember that, this is a super antigen. And then second thing we want to remember is how super antigens work. So, when we looked at the one image, right, and we kind of discussed what goes on when you have antigen binding to T-cell receptors, right? So we all remember the difference between what's going on here with the toxic shock situation versus when we have antigen being presented by antigen-presenting cells on MHC, right, to the T-cell receptor. Everybody remember that? Okay. So, so with here, unlike the antigen situation, we have an epitope being recognized. Here we're going to have this constant, activation and production of cytokines, okay? In the regular situation, when the antigen is presented, MHC molecules will interact with, CD4, right? You have the epitope, interacting with the T-cell receptor, right? And once, the interaction is taking place and we've already started signaling, right? We kind of, disengage, T-cell gets activated, produce the cytokines needed, but, we can have regulatory processes damp down the amounts that we produce. Not so for what happens with the super antigens. And so, in addition to, the one super antigen molecule that's important, for the toxic shock syndrome, don't forget that, we're dealing with a gram-positive cell. There are going to be other exotoxins that are going to be produced. And the first cases, that were reported and led to all the increase in the investigations of this super antigens and so on occurred, because of the recognition of the organisms being present in these superabsorbent tampons. And there was actually a change in the industry, the manufacture of these products to have them not be so super absorptive, so that the length of time individuals would have these would be reduced, so that there would not be the increase in cell growth and then the toxin production.
Can you explain how the antigen binding is different with the
right. So the antigen binding. So again, for T cells, right? So the first thing we remember is that T cells cannot recognize antigens on their own. So they need to do so, recognize the antigen once it's been presented to them on MHC backgrounds, either MHC class 1 or MHC class 2. So for T helper cells, right? We have this, being presented, with MHC class 2. And so when the cells engage, in addition to the, adhesion molecules you have, on the APC and the T cell, we have the CD4 interacting with MHC class 2, the epitope interacting with the T cell receptor in the variable regions, and then activation of the cell. So once the T cell gets activated, right, we begin to signal, through, the CD3 molecules, and, we're going to, generate the transcription factors that are going to allow for particular cytokines to be made. Once we have those, we damp down. But in the case of the superantigens, right, you have the superantigen binding onto, the V beta region of the T cell receptor, and it's also, on the MHC, and it just stays on. So that, the T cell is just constantly stimulated. And you have this activation that just goes on. And we keep producing all these cytokines, there's no regulation. And so those cytokines, activate, other cells, and, some of those cases, the cytokine interaction in the receptor on those cells also leads to additional cytokine production. So you have this, storm of cytokine production that occurs. And that's why it is so dangerous. Okay? So yes, we're binding in the same regions, but the mechanism is different. Right. Okay, does that make sense? Okay. And so, so here, again, we're responding to those superantigens. We have this cytokine storm going on. And then what those cytokines will now do as they interact with receptors on cells, right, will lead to these are things that we see here. So low blood pressure, fever, diarrhea, etc., and it can actually lead to death. And so, these superantigens, can be important in that way. And so this particular one, like I said, has been studied for a long time, because it was first described, and like I said, it led to changes in industry practices in manufacturing to ensure that, people would not, be succumbing to this superantigen in the way that they were. So we have resistant organisms, right? So we have methicillin-resistant Staphylococcus aureus, and there's a lot of concern about it. And in the things that we've talked about with caries and talked about with periodontal disease, you notice that we don't have antibiotics being prescribed every which way, right? So preventive things occurring first, and then in situations where we can't keep that the bacterial levels down with using the antimicrobial preventive approaches like the rinses, and if we have systemic involvement and we're not able to get inflammation levels down, then antibiotics will be prescribed. And so we will also see that when we look at endodontic situations, right, we'll see there more of a need to want to prescribe than, with the things we've talked about. And that is because, again, if you have treatment failure and, you still have bacteria, you're not able to get the bacterial levels down, and there's concern about the bacteria being able to leave the oral cavity and get, into this circulation, then there might be a need to treat. And so when we talked about this yesterday, we mentioned W.D. Miller, okay, Willoughby Miller. So he's the one that's considered the father of oral microbiology, okay. And so so you see two designations with him as an oral microbiologist and as a dentist, and he was actually from Ohio. So, but he's the one that came up with this whole business of saying that you can prevent by reducing or eliminating the bacteria, right? And by so doing, resolve the infections that you have in the mouth. So he was one of the first proponents of that. And so after he came up with that, pretty much it kind of got into the practice and so on. And so the point that we are making with this particular slide over here is this business of the resistance developing, so that we don't want to use the antibiotics when we don't need to, okay? Because again, we're looking at resistance that can develop. And so here, the MRSA, okay, is of great concern because from what we've talked about, we have gram-positive organisms, the penicillin, either natural, semi-synthetic, you would expect to work, right? But then here we have organisms that are now resistant to things like the penicillins, the semi-synthetics, the spinosporins, and so on. And just like we see going on with things like Clostridium difficile, in hospitals and so on, and with Candida aureus, right? So before these two, we had MRSA, okay? And so again, you have community transmission, within hospitals. Individuals that are in the hospital may acquire these, and they can be involved with, serious infection, and in some cases, fatal infection. So resistant organisms in all aspects, in dentistry, in medicine, serious problem. And we see these, as we already mentioned, even with parasites and so on. One of the things, in public health that you always, have nightmares about is, the development of resistance to drugs that are standard therapy in practice. And so we want to remember MRSA. We want to remember what, what the full name stands for. So we have, in addition to the penicillin, to the natural penicillins, also the semi-synthetics. And so again, methicillin-resistant Staphylococcus aureus is what this is. And so again, you see the lesion over there that, under normal circumstances, in sensitive strains, that would have been taken care of, but in the resistant situation, difficult to resolve. And so treatments, when you have staphylococcal diseases, would include, incision, drainage, purulent, if you have exudates, draining them. Again, looking for therapy, that would be effective, so if you have resistant strains, looking for what it is susceptible to. But, there's a whole list of the different penicillin derivatives, where these organisms are resistant. And the simple, things, hand washing and aseptic technique is very important. And so, no different from when carbolic acid or phenol was first used. And if you remember the history of that, where the physicians, would, come from working on cadavers and go directly to delivering babies, okay? And when the suggestion was first made to, wash hands, right? Individuals like Sam-Yellowe and so on, they were just ridiculed and just really punished, for suggesting that, doctors should wash their hands. And so when, it was shown, with evidence that if you washed before you attended, the births, that the death rate, was greatly improved. And it took a lot of doing, to finally get, the physicians to just do that. And then following that up, was the use of the carbolic acid, which even reduced, the death rates even more. And so we see that even today, okay, the same practice of hand washing is enough to, reduce the spread of bacteria as physicians go from patient to patient, or the healthcare staff go from patient to patient. And so if we compare, right, the staphylococcal diseases, the streptococcal diseases that we see over here, right, we can have, superficial type cutaneous diseases, things like cellulitis, impetigo, and so on. And we can, have the organisms, move even further deep into the tissues to, cause infections into the underlying muscle. So if we look at some of these things, so cellulitis, we can have in the subcutaneous tissue, organisms can spread, and sometimes, these can be seen as you look at the skin, the redness of it. And so, you can also have swelling associated. Impetigo, you can have not just strep, but also staph. And again, you can see these lesions, with the red water around them. erysipelas occur, and you can have, acute infection of the dermal layer of the skin, and again, the bacteria being present over there. And so, you see these red patches that occur. And so in this case, both strep and staph can be important in these type of things. Compared to staphylococcus that we just looked at, we can have invasive strep infections as well. And strep pyogenes always comes up. Okay, so we can have invasive infections with strep pyogenes as well. And so again, we can have, just like we saw with staph, we can have in here, exotoxin production, and we can also have, superantigens, and we can also have proteases, that can destroy tissue. And so pretty much, what we're seeing over here is an effect, from these organisms. So we have, the necrotizing fasciitis over here. So we see flesh-eating bacteria. Everybody's heard, people talk about flesh-eating bacteria before. And so these can cause, quite a bit of damage, and very quickly, okay? And so in the pneuma that we saw the pictures of, and remember we mentioned, this polymicrobial nature of the infection, and not being able to attribute it to just one or two, bacterial organisms that may be important, right? And so the destruction that occurs, in there is one of the things we're going to look at on Monday. You can see, that extensive damage of the tissues around the face and so on. So we've had the bacteria go underneath all the way to the musculature in terms of the damage that's being caused. And so, we can have inflammatory responses, the skeletal muscle, fat tissue gets destroyed. And so very similar to what happens when we have the superantigens, we can have, blood pressure drop, rapidly, and then we can also have, multiple organ involvement. And so a lot of the things that we're talking about with the organisms that we have in the mouth, trying to understand them, in those very severe cases, again, remember, we're dealing with organisms that are related. And so all of the strep organisms that we have, right? So in situations, where we have, if you will, the right balance, of populations within, within the biofilms in there, we may not see extensive things like this, but when we have that interplay, crosstalk that you have going on between, strep and porphyromonas and, lactobacillus and, treponema and so on, right? And if we don't have any intervention, we can have, quite a bit of destruction of tissue in the oral cavity in individuals. So as we finish over here, I just want to move on, so I did the same thing. Okay, so just a little bit about antimicrobial drug resistance. So remember how we did things. We looked at what organisms need to survive, right? We talked about how we culture the cells, how we can work with them. And then we looked at, the combination of organisms, that can be found, in biofilms and so on, all the way to the discussion of the red complex that we just did now. We talked about the antimicrobial agents, and right now, we know the targets of those drugs. So everything from the peptidoglycan, cell wall, right, plasma membrane, right. We talked about the polymyxins. We talked about targeting transcription, DNA synthesis, the ribosome, all of these different things. And so we mentioned, as an example of how resistance can develop, the presence of enzymes that we have, within the periplasmic space, for example, in gram-negative cells that can break the beta-lactam ring, okay, that we talked about. And so we want to see other aspects of antimicrobial drug resistance. So, how do they do this? Okay, so we just looked at the methicillin-resistant Staphylococcus aureus, where we're now resisting, several different, combinations of drugs. And so we asked the question, how do microbes become drug resistant? There are several things that can happen. So the organisms can adapt to selective pressure, You can have genetic changes, mutations that would occur that, would lead to the drugs not being effective. Everything from being able to modify the transporters of the drugs into the bacteria and so on. So again, adaptation to blood pressure is important. We can have the different drug-resistant genetic changes that occur. And so the CDC estimates, and this number may be more by now, that about 2 million people will contract bacterial infections in hospitals yearly. So one of the things that's really a hot topic today, and not just within the US, I mean, you have public health officials in several countries, kind of scratching their heads trying to figure out what to do about Candida aureus. Has anybody heard that? Read anything, looked at it, right? So it's a big issue. So we have Candida albicans, okay, which we know we can also find on the body, and depending on what's going on, we can have it be opportunistic. But we have Candida aureus, and people are very perplexed. They don't quite know where it came from and how it is now so entrenched inside hospitals. And so that you have the fear, okay, and so within the healthcare areas, they don't want to talk about it too much, but at the same time they cannot not talk about it because we don't want people coming in and having hospital stays and getting infected, and then now it gets in the news and it's everywhere. So there's this tension that's going on between how much should we say, how much should we not say, but first we had, Clostridium difficile and all the issues with that, and, people acquired in hospitals. And now, you have fecal transplantation type processes that are helping, okay, kind of keep, levels down. And then now we have this Candida aureus situation, and it's kind of taking over. And so, in this number that we have here for, bacterial infections would have to be included, things like, Candida aureus. Okay, because you have people contracting it within hospitals, getting it, there have been fatalities, and very difficult to get rid of. In the first case that was looked at, the patient room, once they went in to do the evaluation, practically every surface of that room had Candida aureus on it. Everything from doorknobs to light fixtures to the table to the wall and so on. And then of course you had to be coming in and out, so which means potentially they're carrying the organisms around as well. So drug-resistant organisms, really a big issue. And so within this number, and again this is smaller than where things are today, right? So a large number of individuals die. And so about 70% of those, bacterial pathogens, causing the infections, are showing resistance to at least one antimicrobial, agent, one antibacterial drug. And so this is important. And so, the next question is, so what is the evidence for selection for resistance in clinical settings? And there are a number of things that come up. So, changes in the way antimicrobial drugs are used. So we have antibiotics, in the food industry, in the meat, as animals are raised. So you have these antibiotics everywhere. And so the thing is, having that increasing use is also contributing to the things that are being seen. So the changes that we have, positively correlated with the changes in the prevalence of resistance. And so if we have increasing antibiotic treatment lengths, this also increases the resistant, microorganization rates. And so the more we're using these drugs, in particular facilities, hospitals, etc., the more that the drug resistance, will occur. And so one of the issues here also has to do with when the antibiotics are prescribed and having people finish a course of treatment. So that, if the course of treatment is not finished, then the chance now of having organisms that will now resist that drug becomes very high, okay? And we'll see how that pattern develops. And so individuals who, already have resistant strains in them, additional drugs, get given to them, and that increases the selective pressure for the organisms. So, it's a real important situation. And so, in the same way that we talked about the targets for the drugs, right, on the membrane, DNA synthesis and so on, we can also look at the cells, as shown here, to understand how the resistance occurs. So if you look at the picture, and we'll start with this slide. So we have, inactivation of the drugs, right? We can have the drugs, the binding sites for them altered. We can prevent access, to the drugs. So organisms can essentially, if you will, spit out the drug. Okay, it comes in, they put it right back out. Okay, and then they have development of very effective, pumps, that essentially will pump out the drugs, once they come in, and so it becomes, totally useless for the organisms. And so you can have, resistance genes. Okay, so if you look in the picture, right, that circle inside the middle there, that's a plasmid. So we can have the plasmid encoding molecules that will help with the resistance. And then, we can also have, drug inactivation, right, where the bacteria produce enzymes that will degrade the drugs. So, which means, in terms of being able to have, good drugs and effectiveness of those drugs, we pretty much have to be like several steps ahead of the bacteria for, having these drugs available. And so, if you want to remember, just like we did for the drug targets, we want to be able to recognize, some of the things, that the bacteria can do to, prevent the drugs from being effective on them. Okay? So we'll stop here, and then when we come back on Monday, right, we're going to look at some of these other diseases, pathogenicity. We're going to look at epileptic lesions. Talk about that. We're going to look at, the case studies I mentioned to you. Look at what happens, with those congenital developmental type of conditions. And then we're going to look at systemic implications for when bacteria leave, the oral cavity and get into the vascular system. And any questions about the things that we've been talking about?
There was one question that you included that we didn't discuss regarding the organisms identified as global epidemiological studies for major contributors to periodontal disease. Because it has T. denticola, T. forsythia, and P. juvenalis, which we discussed, but then it also has the aggregated bacteria.
Right, and that's the one associated with the aggressive, the aggressive disease. Yeah.
So we wouldn't say it's a major contributor to periodontal disease because it's only associated with
except in the aggressive case.
Okay.
Yeah.
What slide is that? 99.
Yeah. And so, and again, some of the studies, and so when we look at the case studies, there is, a little study that we'll look at, just, like the highlights of the study. And so, the people who are interested in, in these types of questions, right? So, at what point, okay, if you are managing a patient and they come in, they have some other disease, they have other underlying conditions going on, and at what point, would you say that your treatment of them, okay, for the oral disease, right, is finished? Does that make sense? Right? So at what point do you do that? So, right, so with some individuals, they're still going to have to do regular visits and so on, and treatment, slows down, right? By the next year, okay, they ended up with the same symptoms again, right? And so this is one of those situations where, okay, we reduce bacterial load, we're cleaning, we're doing the antimicrobial rinses, we're doing everything we can to keep these numbers down, right? But then we also have to manage the chronic condition if there's, that going on, right? To make sure that, we don't keep having this cycle go back and forth, right? And so that might be the situation where not just, the dental practitioner is seeing that patient, but you're also kind of dealing with the medical stuff as well, keeping up, right? So these are important, important things, because, if you look at, if you just go to a regular store and you look at all the things we have for antimicrobial, cleaning and prevention and all of that, I mean, it's vast. I mean, it's, the new things almost every day, right? And then the question comes back, okay, so it's all those statistics, right? How do we improve those statistics, right? And so the research, when you read, the individuals who do this work, their concerns, so as I mentioned, not every practice is going to be isolating bacteria every day. But in the research, environments, individuals who, are researching, these organisms and profiles and so on, right? They will isolate organisms, from patients. So they have them as part of studies, they enroll in studies, and so they will collect, plaque, they will collect samples, they will, grow the cells out. In some cases, even, they'll have the little chips implanted so they can see how much bacteria grows within 2 days, within 7 days, whatever. And not only that, but to really find out, to get a good sense of how we recolonize, right? Some aspects of the study will have individuals, not do any intervention at all. So no brushing, no whatever, for a day, 2 days, to see, okay, how are these cells, the populations, coming back up, So it's it's a, to me, fascinating area of study, people are doing to really try to understand this, and it's done not just locally, but globally, to get geographic sense of how things work. So we'll say a little bit more about that on Monday.